ما بعرف اذا في حدا من الزملاء الاطباء صار عنده DVT او BE لمرضى. It is a very catastrophic complication انه مريض داخل يعمل elective surgery يصير عنده BE او death. ولهذا ال VTE prophylaxis is mandatory because VTE, venous thromboembolism, is a leading cause for morbidity and mortality. And also it's a spectrum. يعني في مرضى بيكون عندهم asymptomatic DVT unnoticed. في مرضى may present with fatal massive BE. So this is a spectrum, and we have the problem of VTE complications, which we have the early complications, and this is the pulmonary hyperembolism, and we know that this could be fatal, and even pulmonary embolism may lead to pulmonary hypertension and right-sided heart failure in the future. So this is the early complication, the venous gangrene, which is uncommon, and we have the late complication, the pulmonary hypertension with its consequences of right-sided heart failure, and also the post-thrombotic syndrome. This is very devastating for the patient to have this syndrome. And also we have the recurrence risk of DVT in the future. And we have the 10-year cumulative risk about 40%. يعني إذا المريض صار عنده الآن DVT, over the coming 10 years عنده risk for recurrence 40%. في كأنه صوت بس خلوا ميوت إذا سمحت. Now, VTE complication, venous gangrene, pulmonary embolism, post-thrombotic syndrome, very important. The VTE incidence without prophylaxis, look how the major the complication, the problem. Without prophylaxis, the incidence is 10 to 40% of hospitalized patient. يعني بنحكي عن نسبة كبيرة من المرضى اللي داخل المستشفى بصير عندهم VTE. In orthopedic surgery, the risk is 40 to 60%. يعني ده mean 50%. يعني نص المرضى اللي بيدخلوا يعملوا عمليات major surgery ممكن يصير عندهم VTE إذا ما بنعطيهم prophylaxis. But this is why we give a VTE prophylaxis. Pulmonary embolism is responsible for 5 to 10% of death in hospitalized patient. يعني نحكي 1 من كل 10 بيموتوا في المستشفى السبب BE. في الأورثوبيديك surgery 2 to 3% الفيتال BE 2 to 3% after elective hip replacement. يعني 2 ل 3% بيموتوا إذا ما أعطيناهم prophylaxis. وبالنسبة للهيب fracture النسبة أعلى يعني double نحكي عن 4 to 7%. You see how is significant this problem in general and also in our orthopedic patients. With routine prophylaxis, the fatal pulmonary embolism is uncommon. Alhamdulillah, it's uncommon with prophylaxis. And the rate of symptomatic VTE within 3 months varying from 1.3 to 10%. And you see this is variability. Why? Because we are dealing with different group of patients, because we have different risk factors, not only the surgery or the type of surgery. So it's a serious complication during and after hospitalization, and also it's a preventable cause of an in-hospital death. What are the risk factors? كم orthopedic surgeon عندنا بالحضور؟ سامعيني؟ كم orthopedic surgeon؟
يس.
في حدا يجاوبني من هناك؟
دكتور عدنان تقدر تجاوبنا؟
أنا مش سامعك على كل حال. طيب.
دكتور عدنان مش هل سامع؟
الحضور حوالي 40 طبيب.
ما شاء الله ما شاء الله ممتاز. طيب احنا الorthopedic surgeons I think know the importance of this problem. The risk factors, we have general acquired risk factors for VTE. العمر من أهم الأمور العمر. يعني مجرد إنه الشخص أكثر من 40 سنة المريض with surgical intervention he is at risk for DVT. إذا كان أكثر من 60 سنة مجرد مش surgery medical procedure he is at risk of DVT. إذا أكبر من 75 سنة without additional factor he is at risk of VTE. ولهذا العمر is very important risk factor. The other all we know is the obesity, زيادة الوزن, smoking. So for that reason if elective surgery المريض morbidly obese or smoker you can postpone surgery, delay the surgery till decreasing weight, and cut off smoking. So these are important risk factors for DVT. Trauma or surgery, and I'll talk about this in details regarding trauma and surgery. Extended immobilization. احنا الان بالهيب فراكتشر وزملائنا بيعرفوا في الهيب فراكتشر it's emergency. ليه؟ لانه we have to get the patient out of bed as soon as possible. شريك we consider it الهيب fracture as emergency should be done within 24 hours if there is a correctable disease within 72 hours. So because immobilization is a major risk factor to develop VTE. A history of previous VTE. This is, I think, the most important major risk for DVT, VTE. So this needs special precautions. Varicose vein, also factors relating to pregnancy, like مثل ما حكت الدكتورة إحسان, pregnancy, البربيريوم, oral contraceptive pills, hormonal replacement therapy, and also we have other group of patients like the cancer patient. We know the cancer patient have a hypercoagulability status, antipsychotic therapy, also an acute disease. All these are at risk for DVT and VTE. Now we have what we call it the economic class syndrome. Anyone know about the economic class syndrome? دكتور عدنان؟ تسأل الحضور؟ The economic class syndrome. Now اللي بيعمل عمليات لمرضى بيجوا من خارج البلد أو من محافظات في البلد في نفس البلد إذا بده يسافر مسافة. الايكونوميك كلاس سيندروم إنه المريض يقعد في الطيارة الايكونوميك كلاس. سامعيني؟
الصوت واضح يعني.
نعم. في حدا بيعرف الايكونوميك كلاس سيندروم؟ اوكي. لما يسافر المريض في الطياره في الايكونوميك كلاس بيكون منزل رجليه. وهاي this is a risk factor حقيقه for DVT. مشانك احنا روتين in our practice لما بنعمل عمليه لمريض من خارج الاردن او ساكن في المحافظه بنحكي له ضروري اثناء الرحله ترفع رجلك. مشانك اللي بده يسافر في الطياره بنحكي له لا تحجز ايكونوميك كلاس وانما احجز بالبزنس كلاس على اساس تقدر ترفع رجلك بالطريق. اللي بيسافر بالسياره بنحكي له اجلس بالخلف وارفع رجلك وضلك حركها طول الطريق. ولهذا الايكونوميك كلاس سيندروم انه increase the risk of DVT because of sitting for long time، يعني انه منزل رجليه لفتره طويله. وهذا مهم مش فقط في السفر. لما بنعمل مرضى للعمليات ضروري انه لما يروح للبيت بعد توتال هيب او توتال ني او هيب فراكتشر انه نحكي له دائما لما تجلس ارفع رجلك وضلك حرك القدم لانه the best mechanical pump for the venous circulation is the muscle. ولهذا this is very important and I think should not be missed by our colleagues. Now we have other factors which are the inherited risk factors. هذول اللي عندهم factor 5 laden, protein C, protein S deficiency, and we don't do screening program for this patient. But if any patient has family history, you should take this very serious because they are at risk. يعني أنا مرة من المرات عملت ACL لمريض. ACL this is simple surgery, and I did give him prophylaxis. Though despite of prophylaxis, he developed a BE and was admitted to ICU. ولما عملنا له الورك اب تبين انه عنده الفاكتور 5 laden. So imagine if we did not give him VTE prophylaxis. This may lead to death. ولهذا very important these factors if you have any family history or previous history we should take in consideration and give a special consideration regarding prophylaxis, not only chemical but also mechanical methods of prophylaxis. Now trauma and surgery. And this is our concern as orthopedic surgeon, because there are risk factors associated with the surgery, like the length of the surgery. Imagine that if you do surgery more than 30 minutes, this is a risk factor. And any patient over 40 years, this is a risk factor. In orthopedic surgery, in neurosurgery, in abdominal surgery, gynecological surgery. So this is very important. And also, we have the problem with the lower limb, like if we have major trauma to the lower limb, so this is a major risk for DVT and VTE, and also fractures or procedures which involve plaster or extended immobilization. So these are again risk factor for VTE. Some vascular exploration, and this is a message because we have to take care, especially as a surgeon, we will do exploration to take care of adjacent vessels, not to cause trauma for these vessels, especially with retractors. Central venous catheter is a risk factor, renal transplantation. Now, if you see the types of surgery, like inguinal surgery, neurosurgery, gynecological, you see that the elective hip surgery, hip fracture, and total knee are the highest risk for DVT and VTE and BE. So this is very important. Our orthopedic surgeon, our orthopedic patients, all of them with this major type of surgery, all of them needs prophylaxis. Now, the other question is for how long is the risk for DVT? If you see here, the orthopedic patient has the high risk regarding the time of risk. So it's 4 to 6 weeks. So even after discharge from hospital, they are at risk for VTE. Why orthopedic patients? You know the virtuous triad, تعرفوا virtuous triad for coagulation or clotting. We have 3 problems: the venous blood stasis, the endothelial vascular injury, and the hypercoagulability status. And all of these parts of virtuous triad, they are present in our orthopedic and trauma patients. Now, in the absence of this pathophysiologic process included in virtuous triad, the VTE is not usually developed. يعني بمعنى آخر لازم يكون عندنا هدول الثلاث أو واحدة منهم على الأقل عشان يصير عندنا ال DVT. Now, our orthopedic patient stasis, the use of tourniquet, immobilization, and bed rest, these can cause venous blood stasis. And regarding tourniquet, most of you use tourniquet, but the question, do we need it for all types of surgery? So we have to minimize the use of tourniquet. Personally, myself, I don't use tourniquet in simple arthroscopic procedure. Even in ACL reconstruction, I use tourniquet only at the time of bone tunnel, making the bone tunnel. So tourniquet use should be decreased and used only if necessary. The immobilization, our aim always to get our patient out of bed as soon as possible. And remember that even if your patient at the bed, يعني حتى لو كان في السرير, he should do the anti-DVT exercises. Surgical manipulation, and so we have to be careful about the manipulation of the blood vessels, especially when using retractors and human. This is very important. We have to take care of the blood vessels. And also, we know that the trauma itself can increase the thromboplastin agent. And also, the use of bone cement, polymethyl methacrylate, it can increase the coagulability status, leading to hypercoagulability status. And this is a risk factor to develop VTE. Now, VTE prophylaxis is mandatory, and we should be adherent to respective guidelines in our orthopedic patient who having these major orthopedic procedure. So the other question, now we know why we have to use VTE prophylaxis in our orthopedic patient. Now the second question is when to use it. All our patients need VTE prophylaxis. We know that the highest risk to develop VTE problems are total hip patients, total knee replacement, and hip fractures. So these should have prophylaxis. Now, the ACCP, the American College of Clinical Pharmacologists, classified in hospitalized patients without VTE prophylaxis in 3 categories. Those who have low risk, moderate risk, or high risk. And our orthopedic patients, total knee, total hip, and hip fracture, all of these are at high risk alone, even without, if they don't have other risk factors, not smoker, not obese, no previous history of DVT, whatever. مجرد انه هو جاي يعمل عملية total hip, total knee, او عنده hip fracture, هو at high risk. Now, included in this category, the major trauma or multi-trauma patients, and also those with the spinal cord injury. Now, what about the knee, the other simple orthopedic procedure, like the knee arthroscopy, isolated lower leg injury, like مثلا ankle fracture or isolated tibia fracture, the upper limb surgery, shoulder arthroscopy or arthroplasty? What about these patients? Are they at risk for DVT? This is a controversial issue. The reported incidence of DVT prophylaxis after simple knee arthroscopic procedure, look, it varies from 0.2% to 18% in the literature. So this is variation. Why? You know why? Because we are not dealing with a single group of patients. They are heterogeneous. Each patient has his own risk factors. So the procedure itself is part of the risk factors. So till now, there is no consensus on VTE prophylaxis after knee arthroscopy. I think each patient should be individualized. You see what risk factors. Now, the ACCP guidelines, there is their suggestion is no VTE prophylaxis for patient undergoing knee arthroscopic procedure if there is no previous history of DVT. Now, the NICE guidelines, which is the National Institute for Health and Care Excellence, they suggest that low molecular weight heparin should be used for 14 days for patient undergoing arthroscopic procedure. مين هم هذول المرضى اللي نعطيهم؟ اللي عندهم total anesthesia time, not surgical time. The anesthesia time إذا كان more than 90 minutes, and if there are risk factors for VTE outweighs the risk of bleeding. So, by conclusion, you have to individualize your patient with this simple procedures to whom to give and not to give. So what about isolated lower leg injuries distal to the knee? Again, the routine use of VTE prophylaxis is controversial. The ACCP guidelines suggest no VTE prophylaxis in isolated lower leg injury. But again, look, the NICE guidelines suggest that we have to give prophylaxis in patients where there's injury or immobilization whose risk outweighs the risk of bleeding. So again, you should individualize your patient. There is no consensus, but you have to decide to whom you should give prophylaxis. Upper extremity, the same. There is no recommendation, not yet established, and the standard care for after shoulder replacement surgery with no prophylaxis. Still, this is the standard, that there is no need for VTE prophylaxis. Now, the NICE guideline, again, they suggest when the surgery is more than, the anesthesia time more than 90 minutes, يعني أكثر من ساعة ونص, you should give. And also, if these patients have difficulty to mobilize after their surgery, يعني إذا مريض كبير في العمر يحتاج ايديه، يحتاج الووكر ليمشي، لما بتعمل له upper limb surgery interfere with his mobility, so you have to give VTE prophylaxis. For how long? This is another question. And look here, the rate of venographic documented DVT without VTE prophylaxis in major orthopedic surgery, like يعني مثل التوتال ني والتوتال هيب والهيب fracture. إذا ما أعطينا DVT prophylaxis, لاحظ the risk of DVT 40 to 60% within 7 to 14 days, and the risk of proximal DVT 10 to 30%. ولهذا مرضانا, they are at risk to develop DVT and VTE even after discharge from hospital. Now we know that hypercoagulability status still for 6 weeks after hip fracture, and the venous function impairment is also there up to 6 weeks after a hip fracture. So these patients are at risk to develop DVT. And this not only within this period, still there is evidence in the literature that the VTE can occur up to 3 months after total knee and hip arthroplasty. 3 شهور. And VTE is the most common cause of readmission after total hip replacement. يعني المرضى اللي عادوا دخلوا للمستشفى كان أكثر سبب لعودتهم لدخولهم ال VTE. So this is a significant risk in our patients. Now, look, 20% of total hip replacement patient لما روحوا للبيت كان ما عندهم DVT documented by venography, and these patients developed DVT 20%, يعني واحد من كل 5 صار عندهم DVT خلال 3 أسابيع. So the risk is still extended longer than after discharge from hospital. So the current ACCP guidelines is to use VTE prophylaxis for these patients at least for 10 to 14 days, يعني أسبوعين, and up to 35 days. And we know from the literature that the risk of the peak incidence of symptomatic DVT after total knee replacement usually 16 days. After hip replacement 27 days، يعني بعد الأسبوع الثالث، يعني احنا بنحكي عن نهاية الأسبوع الثالث. في الهيب fracture at 35 days في الأسبوع الخامس. ولهذا these patients needs extended prophylaxis up to 35 days after the operation. Now the question, you know now why we give prophylaxis, when to give prophylaxis, and the question how we do VTE prophylaxis. We have 2 methods, mechanical and pharmacological. And you know, mechanical, the most important, I think, by the mechanical method is early mobilization. This is our target in all patients, early mobilization. And we advise our patient always, لما بنعمل عملية بنعمل الراوند, always نرفع رجلهم, keep moving. We ask them to keep moving لأنه the best pump for the circulation at the veins are the muscle. So if you contract the muscle, you will enhance the venous circulation. So mobilization and anti-DVT exercises at bed. This is of paramount, very important. Now the other methods, the elastic stocking, we call it graduated compression stocking, and this is very important إنه يكون المقاس صحيح لأنه كثير مرضى بيجيبوا هاي elastic stocking بيكون مقاس غلط. هي بتشتغل بالgradient pressure، فلازم يكون الستوكينج بريشر بالقدم أعلى من المنطقة اللي أعلى وتكون أعلى من اللي أعلى منها، ولهذا إذا كان في خطأ في القياس this will work in different way, in wrong way. The other mechanical is the intermittent pneumatic compression device and the venous foot pump. We are not using actually the pneumatic compression device and venous foot pumps. We are not using this routinely, but in high-risk patients, elderly patient, patients who have difficulty in mobilization, the compliance of the patient is low, خاصة مرضى الديمنشيا بعد الهيب fracture. So we have specific indication, previous history of DVT, we use this mechanical measurement. But like any method in our life, they have advantage and disadvantage. Now the pharmacological, we have a list of medications which we will discuss later. Now the advantage of mechanical methods that there's lack of bleeding potential, ما عندنا risk of bleeding. No need for laboratory monitoring, no clinically important side effect, but also they have disadvantage. يعني مش كل المرضى compliant with their use. They need to be worn continuously pre, intra, and post-operatively. And we have lack in the literature, we have lack of powerful evidence that any of the mechanical VTE prophylaxis method that they reduce the risk of death or BE. ما عندنا evidence في literature. So إذا ما بتعطي chemical prophylaxis والمريض صار عنده BE, you are at a big problem. لأنه ما عندك evidence إنه mechanical methods alone are enough. So we know and documented by the literature that the effectiveness of anticoagulant therapy, the chemical method or pharmacological method, may be enhanced by some mechanical method. إذا هم جزء مهم في الوقاية لكن لوحدهم غير كافيين. So we have limitations like the stocking. إذا كان المجر خطأ قياسه خطأ, we have evidence that it can cause impairment of local tissue oxygenation. And also we cannot use it in all situations. Like مثلا إذا عندنا infection أو local ulcer أو open fracture. أو إذا المريض عنده peripheral vascular disease أو إذا عنده severe cardiac insufficiency. So we cannot use these elastic stocking. So these are contraindication to use them. So we have limitations. Now, what about the guidelines? The use of mechanical method in addition to pharmacological prophylaxis during hospitalization in patients with high risk for VTE after major orthopedic procedure. So they are combined with pharmacological and not alone. This is now the evidence we have and the guidelines. Now, what about the pharmacological VTE prophylaxis? Aspirin, unfractionated heparin, low molecular weight heparin, adjusted dose vitamin K antagonist. We have the synthetic pentasaccharide, fundabarinox, and the new oral anticoagulants, all used. So the question, which I use? So we have someone to help us. Now, we have always a balance between risk and benefit. So we have either the medication failed, so our prophylaxis failed, so we have thrombosis, this is a problem, or it's overacting, we give overdose or whatever, and we have risk of bleeding. So we have to weigh the balance between the benefit and risk, the efficiency or the efficacy and the safety. And this is the work of which type of medication. أي دواء أنا مين اللي له الefficiency الكافي الefficacy and يكون safe. نحن we used once oral anticoagulant and there was high risk of bleeding. So في other anticoagulant they increase the risk of myocardial infarction. So which we use, we have to choose according to the evidence. Now, aspirin alone, acetyl salicylic acid, in orthopedic patient remain controversial. The evidence available is of limited quality. ما بنقدر نعتمد عليها. And it's unclear about the dose and duration of administration. So we have limitations. Now, the Scottish guidelines updated in 2015 are clearer about acetyl salicylic acid. Other agents are more effective in prevention of VTE. So they documented that it's less efficient than less effective than other agents used for prophylaxis. So it's not recommended as a sole pharmacological agent in VTE prophylaxis in orthopedic patients. Still, I know surgeons use acetyl salicylic acid, but the evidence is not strong about this practice, and I think their patients still at risk for VTE. Vitamin K antagonist, it's recommended to be used as prophylaxis for orthopedic patients. It can be used, and we have two common vitamin K antagonist drugs used, warfarin, one of them, you know, all of you. And we need the therapeutic INR about 2.5, between 2 and 3, and preferably 2.5 recommended. So these agents need monitoring. And the problem that when we initiate, like warfarin, when we initiate therapy, لما نبدأ بالتherapy, it needs 2 to 3 days to work. بدها يومين أو 3. ولهذا if you decide to put your patient on warfarin, so you have to give other anticoagulant therapy till the warfarin start functioning. So you have to start with heparin or low molecular dose, low molecular weight heparin, and so on. So you cannot initiate today your surgery today to start it today because it needs time. So you need other anticoagulant therapy. Unfractionated heparin, all of you know that, and we use it years ago, and now we don't use it. But still, it can be used for prophylaxis. But the problem, the side effect. So it has short half-life and has side effect. Of these, the non-hemorrhagic side effect. And if you know the heparin-induced thrombocytopenia, this is very bad complication if happen, and because this will lead to bleeding and even lead to thrombosis. Osteoporosis is another risk factor for unfractionated heparin, especially if used for long time. Now, the low molecular weight heparin have a more predictable pharmacokinetic and pharmacodynamic properties because they have a longer half-life. They are more convenient to be used because it's used once or twice daily, and they have a lower risk for non-hemorrhagic side effect than the unfractionated heparin. And you see here the risk factor with unfractionated heparin, it was 2.6%, while in low molecular weight heparin it was 0.2%. You see, يعني بنحكي عن أقل ب 13 ضعف. يعني الهيبارين can induce this big problem 13 times the lower molecular weight heparin. Now, in orthopedic surgery, low molecular weight heparin is significantly superior to both the unfractionated heparin and warfarin for DVT or VTE prophylaxis. This is documented by literature. The low molecular weight heparin is more superior than these methods. Now, the latest ACCP guidelines recommend the low molecular weight heparin as the optimal method for VTE prophylaxis in patients undergoing total knee, total hip replacement, and hip fracture. So this is the optimal. And also it should be considered as the gold standard for VTE prophylaxis in orthopedic patients. Now, what about fundaparinox? This is a specific anti-factor 10, activated factor 10, and it is higher than the lower molecular weight heparin, its effect against factor 10, and it also have longer half-life. The problem that it has benefits because it has longer half-life, it does not inactivate thrombin, has no effect on the platelets, and does not cross-react with the serum of patient with heparin-induced thrombocytopenia. Because if this happens, you cannot use lower molecular weight heparin. You can use fundaparinox. But the problem that we have a close balance between desirable and undesirable effects, prophylaxis and bleeding. The balance is closed. For that reason, the low molecular weight heparin is a better option than fundaparinox regarding its safety. Now, what about the oral anticoagulant? It's also recommended by the ACCP guidelines. We have the rivaroxaban. It can be used in total hip and total knee, and there is research about that, literature. But we have not yet studies about its use in hip fracture surgery. So you can use it, but not for hip fracture till now. Still lacking the literature. What about the dabigatran? And we used that long time before, but I think it's withdrawn from our market. It in Jordan because in the world there were recorded increased risk of myocardial infarction or acute coronary syndrome in patients use this medication. The other most commonly used now oral anticoagulant, apixaban. The latest ACCP guidelines recommend its use as a method of prophylaxis. It has a direct factor 10 activated inhibitor, and the same guidelines that apixaban has not evaluated in hip fracture. So it's not nowadays, it's not used in hip fracture patients. So what about guidelines? Now, by conclusion, in total hip and total knee replacement surgery, the current ACCP guidelines recommend the use of low molecular weight heparin, unfractionated heparin, vitamin K antagonist, fundaparinox, apixaban, and all these methods for at least 10 to 14 days and up to 35 days, يعني 5 أسابيع. And the use of low molecular weight, this is by conclusion, the use of low molecular weight heparin is suggested in preference to the other recommended agents. And you see here the guidelines by different guidelines, the ACCP, the Scottish guideline, American Academy of Orthopedic Surgeon. These are the guidelines. There is a preference of the low molecular weight heparin to fundaparinox. And again, there is a preference of lower molecular weight heparin to vitamin K antagonist and aspirin. Now, this is the Scottish guideline, and you see here, again, aspirin is not recommended as a single pharmacological agent for VTE prophylaxis. In American Academy, still the evidence there is inconclusive. Still, the guidelines still of moderate evidence. So we rely in our practice on the other guidelines. Now, what about NICE guideline? I like the guidelines of this institution. Again, it's the National Institute for Health and Care Excellence. They recommend, it's recommended the post-operative initiation of lower molecular weight heparin 6 to 12 hours after surgery to reduce the risk of intra-articular bleeding. And this is the time of initiation. And this is another question. هذا موضوع حقيقة كمان مش متفق عليه تماما. متى نبدأ البروفيلاكسيس قبل ولا بعد؟ وإذا حكينا بعد كم ساعة من الإجراء الجراحي؟ وهلا رح نحكي إن شاء الله. And by their guidelines, the extension of thromboprophylaxis is recommended for 4 to 5 weeks, extended prophylaxis, combined with other mechanical prophylaxis. Now the question, when should I start to administrate lower molecular weight heparin for VTE prophylaxis in surgical patient? دكتور عدنان، نقدر نسأل الزملاء متى بيبدأوا هم ال VTE prophylaxis؟ مين بيبدأ قبل بيوم؟ كم واحد؟
المايك مفتوح طبعا. دكتور مطهر.
كم واحد بيبدأ قبل بيوم بيعطي بروفيلاكسيس في التوتال هيب والتوتال ني سيرجري؟ تقريبا؟
ما في واحد يبدأ قبل العملية بيوم، ما في أي واحد يبدأ.
الصوت مش واضح. طيب مين بيعطي افتر؟ نعم؟
جاوب الدكتور مطهر، عم بقول لك انه ما في حدا بيبدا قبل بيوم.
طيب مين بيعطي after 6 hours؟
Orthopedics after 12 hours.
12 hours. Now let's go. I'll answer you all. خليكم معي معناته إن شاء الله. Now, this is still a controversial issue. There is agreement, but not full agreement, about the use of this agent at least 12 hours before and 12 hours after your procedure. يعني نبدأ 12 ساعة قبل أو 12 ساعة بعد العملية to decrease the risk of bleeding. لأنه إذا بنعطي within 4 hours before or 4 hours after, the risk of bleeding is high. السؤال ليش 12 قبل و12 بعد، وليش 4 وليش 4 قبل و4 بعد؟ يعني ليش ما يكون في شيء آخر؟ ولهذا في عندنا systematic review. But the problem here, the sooner the administration of the VTE prophylaxis is, the better to decrease DVT and the less probability of VTE. But the problem is with bleeding. Yeah. So if we give early, there is a risk of bleeding, and if we give late, there is a risk of thrombosis. So what's the answer? Look here, a systematic review, and this review studied the relation between the VTE odd ratio and the initiation of lower molecular weight heparin. And what's the conclusion? You see the conclusion. This is a systematic review. The conclusion that the timing of initiation of low molecular weight heparin significantly influence the antithrombotic effectiveness of our therapy. And the practice of delayed initiation, إنه نعطي متأخرين, delayed initiation of low molecular weight heparin prophylaxis result in a suboptimal antithrombotic effectiveness without a substantive safety advantage. مشان هيك السؤال متى نعطي؟ Look here, if you see here المنطقة المظللة،
أنا آسفة يا دكتور،
نعم.
أنا آسفة دكتور، بس إذا بنقدر إنه لأنه في لسه فقرة الكويشنز.
أنا خلصت، أعطيني 5 minutes.
يلا.
لاحظوا هون المنطقة المظللة هي البيك افيكاسي إذا أعطينا الأنتي البروفيلاكتيك لو مولكيولر ويت هيبرين في هاي الفترة 2 قبل أو 8 ساعات، لكن still we have the risk of bleeding. لاحظ المنطقة المظللة الأخرى هنا إذا أعطينا there is potential bleeding. مشان هيك this is the ideal. Look here, it's about 6 to 8 hours to 12 hours. This is the ideal when to give. So if you see here المنطقة اللي فيها تداخل ما بين اللون الزهري والمنطقة المظللة، هاي المنطقة احنا بهيك قللنا الريسك اوف بليدنج لانه طلعنا من الشادو للبليدنج، وبنفس الوقت ستيل احنا بالبيك افيكاسي. مشان هيك الريكومنديشن look this is the conclusion of the systematic review that the interval between surgery and the first administration of lower molecular weight heparin is a critical variable that significantly influences the occurrence of DVT. And what else? The lower molecular weight heparin began in close proximity to surgery and initiated at a half the usual dose. يعني بدل ما تعطي مثلا نوكسابارين تعطي 40 تعطي 20 خلال ساعتين. This will significantly decrease the risk of DVT. وهذا البروتوكول أفضل من البروتوكول إنك تعطي فقط بعد 12 ساعة أو بعد 18 ساعة زي النورث أمريكا. الآن المسألة الأخرى إنه إذا أعطينا قبل 4 ل 6 ساعات أو عفوا بعد 4 ل 6 ساعات this provides superior efficacy compared with oral anticoagulant and there is no increased risk of major bleeding. So البروبلم إذا أعطينا خلال ساعتين قبل العملية still there is a risk of bleeding. And هذا حقيقة البروتوكول اللي بينعمل في النورث أمريكا إنه بيعطوا بعد 12 أو 18 أو حتى 24 ساعة. Still this is a risk for VTE and with no benefit of delaying this. يعني there is no risk of bleeding if we start early. So this is the systematic review. أنا بنصح حقيقة إنكم يعني تقرأوا هذا systematic review. In my practice, I give all my patients prophylaxis 6 hours after the procedure. Whatever the procedure, after 6 hours, I give the prophylaxis. I'm doing this for long years. Alhamdulillah, ما عندنا major bleeding complication. So by conclusion, patients undergoing major orthopedic surgery such as total hip, total knee, or hip fracture are at highest risk for VTE during and after hospitalization. The patient should administer VTE prophylaxis, mechanical and pharmacological. For optimal use of available VTE prophylaxis method, there are several guidelines published اللي احنا ناقشناهم, and the ACCP guidelines for VTE prophylaxis are adequate enough and could be used in daily clinical practice. And also the lower molecular weight heparin seems to be more efficient overall compared with other available methods for VTE prophylaxis. And this is in our practice what actually we use. And so it's recommended by most of the guidelines. It's recommended in preference to other methods for VTE prophylaxis. Now, still there is doubt or skepticism remains about the use of aspirin alone for prophylaxis. So still some controversy about its use. Again, controversy exists regarding VTE prophylaxis after knee arthroscopy or lower leg injury or upper extremity surgery. So each patient should be individualized. You should individualize the risk factor for each patient, and we need more study to draw this conclusion. Thank you, and this is our QR code for our channel. You can هاي المحاضرة إذا تسجلت راح ننزلها بتقدروا تحضروها. وفي عندنا فيديوهات وركشوب ورشات عمل ان شاء الله تقدروا تستفيدوا منها جميعا. شكرا لكم. شكرا. ثانك يو.
شكرا لك دكتور اسعد.
ثانك يو كثير دكتور اسعد، عن جد يعني محاضره كومبريهنسيف وغطيتوا كل شيء انت والدكتور احسان،
الله
يعني
يسلمك.
ما ضل شيء نحكي زي ما بحكي.
بس طولنا عليكم سامحونا.
لا بالعكس بالعكس، هو لولا الشورتج اوف تايم ولا بنحب احنا يعني دكتور جدا المحاضره كانت انترستنج وممتعه زي ما بيحكوا.
الله يسلمك. احنا بنحاول دائما تكون محاضره انتر اكتف، لكن في الاونلاين صعب، والله صعب اونلاين.
صح مزبوط. فانا بحب اشكرك دكتور واشكر دكتوره احسان. بدي اعرف